So number one, I am so happy to be part of that panel. It's been amazing working with you guys. So I'm going to start with talking about 3 studies. And the idea of this is not to present every study that's presented in a major conference, but there are certain studies that really affect the way we practice medicine in lung cancer. And that's what I want to focus on. And the theme of this presentation is the early stage, that's what I'm going to talk about. And by early stage, I'm talking about resectable lung cancer. And in resectable lung cancer, the question that is really a very important question is the adjuvant treatment. What adjuvant treatment should you give? But newly into the horizon now is the neoadjuvant treatment. And we have a recent New England paper. And now we are talking about the neoadjuvant setting that we are going to start with our first presentation, which is really the Checkmate 816. And as you know, on March 4th, the FDA approved nivolumab with platinum doublet chemotherapy for adult patients with resectable non-small cell lung cancer in the neoadjuvant setting. So this is a new field, well, relatively new field for us, because a lot of us have forgotten that neoadjuvant therapy is an option for these patients. Next slide, please. So does neoadjuvant immunotherapy, meaning nivolumab plus platinum-based chemotherapy, benefit patients with resectable stage 1B to 3A non-small cell lung cancer? Next slide, please. So now the design of the study took the comparator arm, assuming that you're interested in that in some patients, neoadjuvant treatment is a good idea. So the comparator arm is neoadjuvant chemotherapy alone. The investigational arm was neoadjuvant chemotherapy with the addition of nivo. And you actually give 3 cycles followed by surgery. But who's eligible for that patient? Really, on that particular study, anybody is eligible provided they have resectable lung cancer, meaning stage 1B disease or higher, and stage 1B defined as tumor more than 4 centimeters, up to 3A disease. And these are the patients that are actually currently eligible for adjuvant treatment. We are going to give them neoadjuvant treatment. Patients should have had no sensitizing mutation, EGFR or ALK mutation, etc. And this is a phase 3 study, 358 patients. And after neoadjuvant treatment, 3 cycles, patients went for surgery, and then adjuvant treatment was optional, including adjuvant chemotherapy or adjuvant radiation, and we can discuss that later on. But on that study, adjuvant immunotherapy was not built in. So what are the endpoints of that study? And that is really important to discuss, and perhaps we elaborate on that in the discussion section. Number 1 primary endpoint, how many patients actually got complete response? Pathological complete response, meaning patients went for surgery and you did not find any cancer. That's the primary endpoint of that study. The other primary endpoint, which is very important, is event-free survival. And we know that event-free survival might be a surrogate for overall survival, but nothing replaces overall survival. And overall survival certainly has been a secondary endpoint, as well as major pathological response. Secondary endpoints I'm talking about. So secondary endpoints is overall survival, major pathological response. And major pathological response mean that you take patients to surgery, you examine under the microscope, and there is less than 10% of the histology is viable tumor, meaning most of the tumor is necrotic, time to death or distant metastasis. We are trying to find earlier surrogates to overall survival because, you know, in the early stage disease, it takes a little bit of time to figure out overall survival. And ultimately, another exploratory analysis, overall response rate, surgery visibility, peri and perioperative surgery, adverse events. And even though these are exploratory analysis, this is a very important question that I'm going to show you the data as well. For the people who got nivo plus chemo versus chemo, how many patients went for surgery, how many patients did not go for surgery, etc. So let us get to the next slide, please. These are the results of the study. Remember, the primary endpoint is complete pathological CR, no viable tumor. In the intent to treat population, 24% of the patients who got nivo plus chemo had complete pathological response, no viable tumor, versus only around 2% on the chemotherapy arm. That's for the intent to treat population. On your right, as you are looking at the slide, we're talking about how about the patients who actually went for resection. That means that there are some patients who didn't actually make it to the resection. Patients who actually went for resection with 30% complete pathological response versus 3% for chemotherapy. And that is an important question, that actually more patients ultimately completed the surgery if they got Nivo chemo arm versus chemo arm. 83% of the patients completed surgery on the Nivo chemo arm versus this 57 is inaccurate. I believe it is 75. So we reversed the number here. It's 75% of the people on the chemo arm went for surgery versus 83%. So there are small numbers of patients ultimately after neoadjuvant did not go for surgery. And I would like to talk about that later on when we are thinking about how can we utilize that neoadjuvant approach. So this is as far as the primary endpoint, we have here in the eyes of some people, a practice changing finding here with neoadjuvant chemotherapy plus immunotherapy clearly superior to neoadjuvant chemotherapy alone. Next slide, please. And again, these are the patient's characteristics, and there are certain factors here I'm going to look at for the event-free survival here, and that's another primary endpoint. Sorry, that's not patient characteristic. I'm talking here about results. Primary endpoint is event-free survival, and event-free survival happened 31% of the time versus 20%. I take that back. The event-free survival in month 31 median event-free survival 31 months for Nivo plus chemo versus chemo alone. Once again, hazard ratio is 0.63. That means that Nivo versus chemotherapy improved event-free survival by 37%. Look here at the bottom of the slide, and you actually start finding some very interesting findings. That as the PD-L1 goes higher, the event-free survival becomes very strongly, I would say, the hazard ratio becomes very remarkable. We have a hazard ratio, if the PD-L1 is more than 50%, the hazard ratio is 0.24 for Nivo chemo versus chemotherapy alone. So for the intent to treat population, clearly, the results of that study tells me one thing. If you are going to consider neoadjuvant treatment, neoadjuvant Nivo plus chemotherapy is the standard of care if you are going to consider neoadjuvant treatment. Next slide, please. So this is the conclusion slide. Neoadjuvant Nivo plus chemo results in significant improvement compared to chemotherapy alone, statistically significant improvement in EFS alone with 37% improvement in risk of progression, recurrence or death. That's a hazard ratio of 0.63. The median EFS 31 months versus 20 months for Nivo-based therapy versus chemotherapy alone. A pre-specified interim analysis for overall survival, hazard ratio of 0.57, didn't quite cross the boundary of statistical significance. Maybe it's a little too early to look at that, and that's why we looked at some surrogates. And the very important factor here that Nivo addition to chemotherapy did not seem to increase adverse events, and actually did not seem to decrease the chances you go to surgery. Actually, the opposite. More patients had surgery if they got the Nivo versus the non-Nivo arm. Next slide, please. So the impact slide is the next slide. I would say here, and we've edited that statement to be exactly accurate. Neoadjuvant Nivo plus chemo versus chemotherapy is certainly improves chances of successful surgery, reduce the risk of recurrence compared to neoadjuvant chemotherapy alone, and should be considered the standard of care for select patients. What do I mean by select patients? These are the patients that you are gonna consider neoadjuvant treatment as a better option than adjuvant treatment. And that's a discussion that we will engage in later on, especially now that I'm gonna move on from neoadjuvant to adjuvant.
Tarek, there's a few questions I want you to address. So in 2022, based on this data, for your stage 3A patient who presents to you, depending on the level of mediastinal lymphadenopathy, which are the patients that you consider for neoadjuvant chemoimmunotherapy versus a chemoradiation approach for induction?
That's a great question. It might take me 2 minutes to that, but that's also will take time off the discussion section. So let me tell you how I feel about stage 3A disease. And Sujit, having worked with me for many, many years, I have been a believer of the potential surgery for stage 3A disease. And that's based on many things, based on results from intergroup analysis, intergroup study 0139, and that there are some patients who benefit from neoadjuvant chemotherapy followed by surgery. And the gold standard is if you get neoadjuvant treatment, you are looking at the mediastinum to downstage the mediastinum from N2 to N0 disease. And I've been an adopter for that new approach for so long until the Pacific clinical trial came. And when the Pacific clinical trial came, we started to improve our outcome for stage 3 disease with a non-surgical approach, thanks to adding consolidation immunotherapy, concurrent chemotherapy radiation, followed by consolidation immunotherapy. So I started to change my practice from potentially resecting 3A disease to moving on to concurrent chemotherapy radiation, followed by consolidation immunotherapy. But with the addition of immunotherapy upfront here and the chances of complete responses happening, I am starting to look back at stage 3A disease for certain patients, and I say, no, these are patients that I actually would like to go to my previous approach, neoadjuvant followed by surgery. So at this point of time, which patients? That is the real question. I love to consider neoadjuvant patients in patients with single station N2 disease, particularly if that single station N2 disease is non-bulky, particularly if it's detected on a PET rather than a CT scan, or even more if it's detected by invasive procedure like an EBUS or mediastinoscopy rather than actually sitting on the CT scan. Because we mix all N2 disease together. They are not the same. A patient that you see N2 disease on a CAT scan is very different than if you see it only on a PET scan, very different than you see it only during an EBUS or mediastinoscopy. So this is number one, single focus N2 disease. Number two, the type of surgery that you might require. So if a patient requires a right pneumonectomy, I try to stay away from surgery. Mortality of right pneumonectomy is still very high, and in some practices it's up to 5 or even 10%. So I still use the concurrent chemotherapy. But if the surgery is lobectomy, or in some situations left lobectomy or left even pneumonectomy, that's a different matter. So I hope I answered the question. In short, single station N2 disease, that a patient that would require lobectomy avoided in a patient that would require pneumonectomy. And during the discussion section, Sujit, I'm going to present a case in whom I actually adopted that neoadjuvant approach and might re-emphasize what I just said. Does that answer the question?
Yes, thank you. Let's go on.
Okay, so moving on from neoadjuvant. So now neoadjuvant, I'm going to talk about adjuvant. Next slide, please. And that's the incorporation of immunotherapy into the adjuvant setting. That's the Empower 010. And we have some updated analysis on that Empower 10, which is the addition of atezolizumab in the adjuvant setting after chemotherapy. Next slide, please. Let us go back to the design of the study. We are talking here about a drug or a regimen that was approved late last year, 2021, addition of atezolizumab or Tecentriq in after chemotherapy, or patients who didn't even complete chemotherapy because of toxicity, for patients in stage 2 and 3A disease with PD-L1 expression more than or equal to 1%. And that's based on the results of the Empower study that we're going to show. What's the design of the Empower study? Well, the design of the Empower study is almost similar. Next slide, please. Here, we took patients. Next slide, please. Here, we took patients, again, that are resectable disease who are eligible for adjuvant chemotherapy. Stage 1B disease, 4 centimeter or higher, and all patients with stage 1B, stage 2, and 3A disease in whom immunotherapy is not contraindicated. Patients had good performance status. And actually, molecular testing here was not an exclusion. If you have a molecular target here, we're not an exclusion in that study. And that's might be relevant in some people's minds. Patients underwent what we call R0 resection. R0 resection meaning the surgeon got everything that they can find. And we don't have positive margins. That's what's called R0 resection. And patients were randomized to chemotherapy followed by adjuvant atezolizumab versus not. Adjuvant atezolizumab was given a year, meaning every 3 weeks for 1 year. And really, the primary endpoint of that study was DFS, disease-free survival, for patients with stage 2 to 3A disease. There was a hierarchical design that is a little complicated statistical design. We can get into that if you want later on, but the primary endpoint of that study is 2 to 3A, and we're going to look at patients with PD-L1 expression more than 1%. What is the impact of adding that immunotherapy at the back end of chemotherapy compared to placebo? Secondary endpoint is overall survival, 3-year and 5-year disease-free survival, and some other exploratory analysis that we might get into later on. Let us look at the bottom line result of that study. And the bottom, next slide, please. And the bottom line result, these are the patient's characteristics, not bottom line results. And all what I can tell you on that study, that patients were well balanced. And it turns out, as you asked Sujit before, a third of patients had an N2 disease. So certainly in some practices, N2 disease is surgical in some people's eyes, but remember, this is surgical N2 disease. This is N2 disease that we might have discovered after surgery as well, which is important, very different than clinical staging at the beginning. These are the chemotherapy regimens that were used, and I want to highlight that around 15% of the patients or 17% of the patients had a GEM-based regimen. This is relevant to myself and to some subgroup analysis that I'm going to show you later on. Patients' characteristics well balanced between lobectomy and pneumonectomy, because these variables are very, very important to potential outcome. And I'm happy to say that it is very well balanced study. Next slide, please. The results of that study on patients with PD-L1 positive patients, more than 1%, 2-3A disease, addition of immunotherapy after chemotherapy. And remember, not everybody got 4 cycles. Some patients didn't even complete the 4 cycles, but the addition of immunotherapy led to an improvement in disease-free survival with a hazard ratio of 0.66 for the intent to treat population that are more than 1% PD-L1. For the intent to treat population as a whole, meaning all PD-L1s considered negative or positive, the hazard ratio is 0.79. But really, when we started to look at subgroup analysis, the benefit was apparent in the patients who are PD-L1 positive, meaning 1% or higher, and was not apparent in the PD-L1 negative. So the FDA made it clear that the approval are for PD-L1 positive patients, which are 1% or higher. For the 1B to 3A, we are not there because really that analysis did not meet the statistical endpoint. So the approval is for 2 to 3A disease for PD-L1 positive, 1% or higher. So in whom are you more inclined to give adjuvant immunotherapy? The approval is PD-L1 positive. But let's look at the next slide. And then it becomes, again, I'm coming to the point how to choose later on. But there seems to be the benefit on the first plot. All the dots are to the left, to your eye, to the unity. So there isn't a subgroup that seems not to do well with the adjuvant immunotherapy, except on a subgroup analysis, exploratory analysis. You shouldn't reach conclusion, are the people who were treated with GEM-CIS. And I've never given a GEM-based regimen to a patient in whom I want to give immunotherapy. This is my personal bias. We give gemcitabine to people we treat with lymphomas, for goodness sake. This is a T-cell suppressant. So in my own practice, if I'm going to give immunotherapy, I shouldn't be giving gemcitabine, and that's something that you might think about for your own cells. But the subgroup analysis is very intriguing and reinforces my own thought on that particular one. Next slide, please. Again, the benefit seems to be irrelevant of the stage of the disease, the presence of N0, N1, or N2 disease. All patients seem to have benefited as far as disease-free survival, and that's for the intent to treat population. Next slide. So in whom do I feel even stronger? Next slide, please. So in whom do I even feel stronger about giving immunotherapy? It's exactly like the neoadjuvant. The higher the PD-L1. So here, when we look at the PD-L1 negatives, there is no benefit whatsoever. That's the first. PD-L1 less than 1%, hazard ratio 0.97, crossed the unity. PD-L1 1 to 49 again, it crossed the unity. But remember, this is a subgroup analysis. For the intent to treat population, anybody with more than 1% benefits. So you should consider it for anybody more than 1%. But I feel very strongly about it. If the PD-L1 is even higher than 50%, you have a hazard ratio of 0.43. Subgroup analysis, again, the next bullet is disease-free survival in the adjuvant setting and platinum-based chemotherapy. Hazard ratio for PD-L1 more than 1%, 0.66. For all population is 0.79. For the more than 50%, I say it again, hazard ratio is 0.43. The approval is clear for 2 and 3A more than PD-L1, more than 1%. Next slide, please. On these prior studies, there were no new safety signal for immunotherapy. And I'm not going to rehash this discussion that we discussed last time. So the impact at atezolizumab continues to demonstrate benefit and should be a practice-changing adjuvant treatment option for PD-L1 more than 1% in patients who had resected 2 to 3A R0 resection. And remember, on this particular study, adjuvant radiation treatment was not allowed. And that was a criticism at the time the study was presented, but right now it turns out to be a blessing, because now we know from the ART study that adjuvant radiotherapy, even for stage 3 disease who had R0 resection, is not a good idea. So do not give adjuvant radiation for stage 3 disease. I'm looking at my watch here. I have a few more minutes. Next slide, please. And that's the last presentation, which is Keynote 091. Remember, we are still in the adjuvant. Now I'm going to look at adjuvant pembrolizumab. And the study is again positive, but it confused me a little bit. And the confusion has not been resolved yet. And I'm going to tell you why did it confuse me a little bit. Let us go to the design of the study. Very similar. Does pembrolizumab provide benefit for stage 1 to 3A disease after resection? Almost the same design as Empower 010 or Empower 10. Next slide, please. Who's eligible? Same eligibility criteria, stage 1B or higher, and had complete resection, R0 resection, must have had tissue. Obviously, there is plenty of tissue after resection for PD-L1 testing. Eligibility, again, adjuvant chemotherapy was recommended, especially strongly recommended for stage 2 to 3A disease. Pembro, 200 milligrams versus placebo after chemotherapy. Primary endpoint is disease-free survival in PD-L1 patients with TPS score more than 50%. Secondary endpoint is DFS in PD-L1 TPS score more than 1%. And let us look at the data. For the next slide, please. Once again, study is well balanced. No concerns here. Once again, 30% of the patient had 3A disease and around 14% had stage 1B disease. How many patients had PD-L1 more than 50%? Almost a third of patients. That's the bottom lines on your right. So look at these numbers. How many patients studied? Very big study, almost 600 patients per arm. Very respectable for being able to finish that study. Next slide, please. Yes, DFS improved with the addition of Pembro with a hazard ratio of 0.76. That's disease-free survival. Remember, I have not talked about overall survival at all yet on any of this study. The primary endpoint has been disease-free survival, not overall survival. Hazard ratio is once again 0.76. P-value strongly positive, favoring Pembro. So why did I say it is confusing? Next slide, please. Please, I cannot explain this. For PD-L1 more than 50%, a third of patients, the study was not positive. And that's mind-boggling because it rocked my confidence, even though it's a one study, but it's again, this is a primary endpoint of that study, one of the primary endpoints of that study. And it is completely opposite what I expected. The hazard ratio is still 0.82, crossed the unity, p-value 0.14. I'm sorry, I cannot explain this. Next slide, please. So this is, again, the study shows relatively black dots favoring the immunotherapy arm on all groups of patients, except crossing the unity in patients with squamous cell carcinoma, in patients with PD-L1 more than 50%, kind of raises some questions that makes me want to stay tuned. It doesn't change my practice of offering immunotherapy, but makes me stay tuned to the future studies that actually we're going to show a slide for more neoadjuvant and adjuvant studies with the Corporation of Immunotherapy. Next slide, please. Overall survival, again, no benefit. Maybe it's too early for that study because the median overall survival is not reached on both arms. Hazard ratio is 0.87, favoring the immunotherapy arm with pembrolizumab. Next slide, please. No new safety signals. Let me put it this way, and that's a good summary, is what you expect. Patients getting some immune mediated side effects leading to treatment discontinuation 20% of the time versus 6% of the time with the placebo, and that's the second boxed arrow in yellow. Next slide, please. So adjuvant treatment with pembro significantly improved DFS in the overall population with early stage non-small cell lung cancer with reduced risk of recurrence or death by 24%. Data for more than 50% did not meet statistical significance. Disappointing as far as I'm concerned. Overall survival data is immature. The safety profile of pembro is consistent with prior experiences. Next slide, please. Pembro demonstrated benefit. This is the impact in the adjuvant setting in patients with early stage, the potential risk for reduced risk of death, more to come on that particular study. Remember, this study has not been presented yet. Next slide, please. Presented at ESMO, I take that back. Okay, so how to choose neoadjuvant versus adjuvant? These are some hypothetical advantages. I'm going to leave discussion of that in the discussion section, but potential advantage of neoadjuvant chemotherapy: you have a patient just fresh, has not been exhausted by anything, higher chances of completing your systemic therapy, able to assess response. In the adjuvant setting, we are taking a leap of faith that patients are responding to systemic therapy. But really, in the neoadjuvant, you are able to assess response and potential downstaging, as we discussed. Potential benefits for adjuvant: it's faster local control. I mean, everybody who has an R0 resection has an immediate local control of the tumor. And relying on the adjuvant treatment to improve survival, higher chance of completion of surgery. Is that a good thing or a bad thing? I could argue that it might not be as a good thing as you think, because, and we can discuss that later on, accurate upfront pathological staging. You know exactly what stage of the disease when you remove it. That's pathological surgical staging. Next slide, please. These are the studies in the neoadjuvant setting. And I would love to talk about that, and we will talk about it. But if you have not adopted immunotherapy, and these are the adjuvant studies that are on the right. So on the left, there are many neoadjuvant to come. On the right, there are many adjuvant to come. And the most important thing is, what are the endpoints on that study? If you have not adapted immunotherapy in the adjuvant setting, or even in the neoadjuvant setting, because the endpoint is not overall survival, you've got to examine we've got to examine our practices in clinical trial design, because almost in every study of the ones I'm showing you, overall survival is not the primary endpoint. And remember, on the Pacific study that gave consolidation immunotherapy, the consolidation immunotherapy was approved based on PFS. It wasn't based on overall survival. Yes, we published two papers. We published New England Pacific on PFS when it was approved. Ultimately, we had overall survival advantage, but that was not what got the immunotherapy approved in the consolidation setting. And I think that is my last slide. Next slide, please. I took a few minutes more than my time because I probably answered some questions in the middle. Thank you so much for your attention.
So, Tarek, I do have one question for you. It's kind of a combined question from the crowd. So, a lot of times in the States, we don't use cisnavalbine, we don't use, cis-based regimens. Would you feel comfortable using a carbo-based regimen in the neoadjuvant setting? And if not, what is your preferred platinum doublet based on Checkmate 816?
So the answer is, we know from a lot of studies that cis is superior to carbo just a little.
Yeah.
So any patient I try to treat in a curative intent, it's going to be cis, unless there is a contraindication. I'm comfortable if a patient has peripheral neuropathy to start with, or a patient has renal dysfunction or hearing loss. I'm comfortable with these patients, but you should attempt giving cisplatin on everybody. My favorite regimen in the neoadjuvant setting, if a patient has non-squamous, would be PEM-CIS. If a patient has squamous, has been docetaxel cisplatin.
A quick question. A lot of questions on the staging. For stage 3, can you give a quick 1-minute thing about the changes between TNM7 and TNM8 for 3A and 3B?
Well, there is no changes whatsoever as far as the lymph node status. So an N2 has remained an N2. It has not changed for the staging of stage 3A disease. Stage 3A disease, the ones that we are talking about here, is ipsilateral lymphadenopathy in an N2 session in the mediastinum, which is right paratracheal or subcarinal in the right side, left paratracheal or subcarinal on the left side, or perivascular. So as far as the N staging, that has not changed, but it has changed as far as the T. So if you have a T3N1, that's a 3A disease. And you asked me the question, Sujit, about surgical 3A disease. So it could be surgical 3A disease, not based on N2 disease. When we talk about 3A that we are considering non-surgical, it is the N2 disease. This is mediastinal adenopathy, is the one that makes a 3A disease or 3A or 3B for that matter, unresectable disease. So again, between AGC7 and AGC8, the lymph node station designation has not changed much. Obviously, there, on the AGC8, we added another component, which stage 3C, and the 3C is when you have contralateral supraclavicular lymphadenopathy.
And Tariq, one last question. I was a little surprised they include stage 1Bs, just the larger tumors in the neoadjuvant approach. If someone is purely a stage 1B, no evidence of radiographic lymph node involvement, is that someone you would still consider doing neoadjuvant on, or would you, because you could give them immunotherapy, and at least right now, it's only stage 2 for the adjuvant immunotherapies?
It is a consideration. In my practice, I've not done that. Okay. In my practice, when you have a patient with no lymph nodes, and N1 or N2, meaning only stage 1B disease, I go ahead with surgery. And you remember the reason we said that, even if you look on the adjuvant chemotherapy results, on every subgroup analysis, the most major impact of adjuvant chemotherapy, and perhaps we can imply to some extent immunotherapy, even though I'm not totally sure it is true, the most impactful outcome is when you have lymph node metastasis. Adjuvant chemotherapy decrease recurrence of disease by 50% in N1 disease on the GBR10 study and on the ANITA study, where actually the impact on stage 1B disease is an absolute benefit of around 8% for overall survival. And that's why even on the Empower 091, adjuvant chemotherapy was not mandated for stage 1B disease. And if you look on studies, you will discover on when you do not mandate adjuvant chemotherapy for stage 1B disease, look at the ADORA study, in real life, only a third of patients would have gotten adjuvant chemotherapy in stage 1B disease. So in my practice, I go up front with surgery in stage 1B disease, but in stage 2 and 3A disease, neoadjuvant chemoimmunotherapy should be strongly considered and should be very strongly considered if you are considering a stage 3A disease, a surgical patient, particularly if the PD-L1 is high, more than 50%.
Last question on the stage 1B before we move on to metastatic. So there's some soft data, at least from some of the trials in stage 1B, that you have a high SUV uptake prior to surgery, poorly differentiated histopathology, or lymphovascular invasion. There may be some benefit in those patients. Now, I know in the IMpower they didn't use any of those criteria. Do you offer routinely for stage 1B with any of these 3 characteristics? Adjuvant immunotherapy, chemoimmunotherapy?
Adjuvant chemotherapy, you mean? Adjuvant
Chemoimmunotherapy, yeah.
Yeah. So let me put it this way. If I'm going to consider adjuvant chemotherapy, I'm going to give adjuvant immunotherapy for anybody with PD-L1 more than 1%, more strongly for PD-L1 more than 50%. But the real reason adjuvant chemotherapy for stage 1B disease, and I do believe that some of these factors you talked about is more important than actually the tumor size more than 4 centimeters. And remember, the reason we said tumor size more than 4 centimeters is 2 subgroup analysis, right? From the CLGB 9633, which was positive, then negative, then we tried to save our face, and we said, well, let's look at tumor more than 4 centimeters. And then from the ANITA study, which looked at larger tumors. But I do believe that lymphovascular invasion or pleural invasion might be even more important. So if I have a patient with a tumor that's 3.9 centimeters, is that different more than 9 centimeters? So I look at more factors than just the tumor size. So I would consider it, and I would talk to the patient about it. Again, these are some suggestions. What I enforce not enforce, but what I strong heavily for chemotherapy is lymph node metastasis. This is the one variable that consistently showed that adjuvant chemotherapy is necessary.